Welcome to this author insight from the Journal of Bone and Joint Surgery. My name is Nicolas Piusi, and I am the Adult Joint Reconstruction Research Director in the Department of Orthopedic Surgery at the Cleveland Clinic. Today, I will share with you our JBJS article, Bilateral Simultaneous Total Knee Arthroplasty May Not Be Safe Even in the Healthiest of Patients. What led my colleagues and I to conduct this study was that nearly 40% of patients who undergo a total knee arthroplasty require a contralateral procedure within 10 years after the index surgery. And even though total knee is one of the most successful and cost-effective surgeries, there remains debate as to whether the benefits of bilaterals outweigh the increased risk in complications, morbidity, and mortality. On the one hand, claimed benefits of bilateral total knees include an overall decreased hospital length of stay, anesthesia time, rehabilitation, and cost. However, bilateral total knees have also been shown to be associated with increased intraoperative blood loss, rates of VTE, systemic complications, as well as periprosthetic joint infection. To date, since only around 3 to 5% of all total knee arthroplasties performed in the United States are bilaterals, and due to the relatively low frequency of complications, current studies often lack sufficient power to determine true differences. Therefore, the purpose of this study was to use data from a nationally representative database to identify if there is a population of patients undergoing total knee arthroplasty in whom bilateral total knee arthroplasty can be safely performed by comparing 30-day complications rate. Using the NSQIP database from January 2012 to December 2018, we identified 8,291 bilateral total knee arthroplasties and matched them one-to-one by morbidity probability, which is a cumulative variable which incorporates demographics, comorbidities, and laboratory data. Overall, we found that bilateral total knee arthroplasty had an increased risk for 30-day complications when compared with unilateral total knee arthroplasty, regardless of health status. For all complications, when comparing bilaterals to unilateral total knee, there was a greater than threefold increase for both the healthiest and the least healthy patients. For major complications, similar findings were seen with a greater than twofold increase for the first quartile of healthier patients. We have to acknowledge limitations such as the limited follow-up, as NSQIP database does only capture events up to 30 days postoperatively. Additionally, NSQIP does not record numerous variables pertinent to arthroplasty outcomes, including mainly sequential compared with truly concurrent simultaneous surgical procedures. In summary, there is a need for an evidence-based guideline to help select patients undergoing bilateral total knee arthroplasty. Our study adds to the existing body of literature to assist in the shared decision-making between orthopedic surgeons and patients, and demonstrates that bilateral total knee arthroplasty may not be as safe as an option for even the healthiest individuals compared with unilateral total knees. We invite you to read the full article in the upcoming JBJS issue. Thank you for your time.